Good morning, everybody. It's a pleasure to talk to you this morning, and I have no conflicts of interest to disclose. The work I'm going to talk about today was supported by a T32 grant and the Regenstrief Innovations grant, with Dr. Barbara Khan, my mentor, being the PI on that study. So, as some of you may not be working in the ICU, I'd like to take you on a journey into what it's like, particularly for patients who have respiratory failure and are on aggressive ventilator modes, and take you through the journey of what it's like for these patients to experience some of the hardware that we place in their bodies and their recovery, and what we're trying to do to face this challenge. So I'd like you to meet Steve, a patient who is admitted to the intensive care unit because he developed acute respiratory distress syndrome. And Steve is 52 years old. He loves to spend time with his grandkids. He has a dog he loves to spend time with, and he listens to Billy Joel. And he gets to the emergency room with difficulty breathing, and they get a chest x-ray that looks very abnormal. It is almost entirely whited out when it should be dark. And because of his low oxygen levels, they place a tube down his throat and connect him to the mechanical ventilator so that they can support his breathing. So he's basically now on life support. And if you watch this on television, you will see how comfortable patients look when they have a tube down their mouth. And in fact, if you watch the Hallmark channel, you don't even necessarily need an endotracheal device. You can just use one of our suction catheters, put that in the mouth, put some tape over it, and the patient's saved. Well, unfortunately, in the intensive care unit, in reality, that is not the case. So this is a picture taken off of Google of a patient who has severe respiratory failure, and we cannot ventilate them. So we have strapped them into this contraption that looks like it's from the medieval times. And that is the patient's face in a vise, and that is the floor. So the patient is being rotated, spun upside down with their face facing the floor while their life-saving devices are kept in place, and everyone's praying that nothing falls out because that would be catastrophic. And this is another patient when the patient's actually, the bed rotates upward and the patient's now facing the ceiling. And they've removed some of the covers so that they can give the skin some breathing time to prevent breakdown. So as you can see, for someone to tolerate this for a week, they have to be heavily sedated. They have to be on paralytics to prevent them from being able to move. And this takes a huge toll on the body. So really you develop acute brain failure, acute brain dysfunction, which is delirium or a confusional state. A lot of these patients will have pain, depression, anxiety, post-traumatic stress disorder if they survive the hospital stay and they survive all of this intervention. So this is an area that Barbara Khan, myself, Sophia Wong, and some of our other collaborators work on, and that's the journey we're going into today. So as I'm describing this, this is a multi-component threat. You have an inciting event of respiratory failure, which leads us to place someone on mechanical ventilation if the respiratory failure is severe enough, and they develop ICU-acquired symptoms from some of these interventions. They might have anxiety, pain, stress. They may get a lot of sedation, which is an independent risk factor for developing delirium and acute confusional states. And then once they develop this, they may have longer ICU stays. They may develop cognitive impairment and dementia at 1 year. Their mortality goes up in both the hospital as well as if they survived 3 to 6 months. And they're more likely to end up going to a nursing facility, to a rehab, to a long-term acute care hospital after. And their risk of developing a post-intensive care syndrome with psychiatric, cognitive, and physical function impairments is very high. So what can we do to kind of break the cycle? Well, to start, we have to look at what's the environment. So in the ICU environment, based on the pictures I showed you and some of the case when you met Steve, you'll notice that there's a lot of There's a high risk of having pain, of having a lot of noise with a lot of beeping devices and beeping pumps. There's sleep disruption. There's stress from both the acute illness as well as everything that's going on around them. There's a dehumanization phase because of a lot of their acute illness and their loss of sense of self and loss of control in the ICU. So how do we change this environment? Well, as some of you may know, the area I work in is in music. So what we're basically trying to do is change one of their sensory inputs using music to change the environment and to basically modulate a lot of these variables within the ICU environment. So why do we use music? Why did we go down this path? Well, this is going to go a little bit into the neurocognitive and neuroscience understanding of music, which is that you hear a sound which gets transmitted and converted in your cochlea, in your ear, to a chemical and electrical signal that gets transmitted to the brain through the auditory brainstem to the thalamus and then goes to the auditory cortex. And there's a lot of processing that's happening as you're listening to my voice, or you may be listening to music. There are areas of your brain involved in emotion, perception, cognition, and the autonomic nervous system that controls your heart rate, blood pressure, respiratory drive. And a lot of these areas communicate together. So you have a multi-system effect. If you hear very slow tempo music, you may start to notice that your heart rate slows down, versus if you're listening to techno, you might notice that your heart rate increases to kind of closer match the auditory stimulus that you're receiving. And this is due to the auditory cortex processing the sounds along with the thalamus. And there are areas based on functional MRI studies of the brain that are lighting up when someone listens to music. Areas that are involved in attention, memory, motor function, emotion, and memory again. So those are the areas that these patients have problems with, both in the ICU as well as when they go through recovery. To try and unpack some of this black box, there is some work being done using EEG. And in this EEG model, they exposed patients to noise, that doesn't really have a certain timbre and rhythm and pitch, versus a selection of classical music that was very rhythmic. And they showed in the red that you have bihemispheric connectivity between the neurons that's increasing based on the electrical stimulus. Versus if you just have noise-canceling headphones put on in silence, you don't have that degree of neural connectivity. So this sort of explains some of that mechanistic model as to why we might see this as a beneficial intervention in these patients who have problems with cognition, problems with attention and memory in the intensive care unit. So what's the current evidence? Well, in the ICU setting, there is little evidence. There have not been any large randomized trials looking at delirium or cognitive function with music prior to our work. And there is limited data on anxiety, for example. In the non-ICU literature and setting, there is evidence that music helps with physiologic stress, so heart rate reduction, blood pressure reduction, improvement in pain, and gait balance in dementia patients, for example. In our work, this is a systematic review we published last year. We looked at if music has been shown to reduce inflammatory markers in the serum and in blood. So the reason to do this is that there's a neuroinflammatory model for delirium, and we wanted to know if there's already some evidence that using music could reduce some of those inflammatory markers. What we found is that in the ICU setting with patients on mechanical ventilation, a lot of the studies, actually all the studies, have poor methodological rigor. And so due to bias, there's low level of evidence that music can affect those markers. The only consistent finding was that cortisol, which is a stress hormone, was reduced, but higher quality studies are needed. And so in our hypothesis, in this model, we would use music to reduce the symptoms because there's already some non-ICU literature that shows anxiety, pain, and stress are reduced. But can we use it in the ICU setting, and can we use it to reduce delirium? We know from our collaborators who did a ICU trial with music, using a music therapist, that anxiety and sedation exposure was reduced. But those were not critically ill ICU patients. Those were patients who were awake and able to interact with their music therapist. So again, the question is whether we can use it with higher level of external validity in a patient population such as the ones we see. So really an opportunity developed. Can we find a scalable intervention? Can we design it, and can we test it, that can be used in the logistically difficult ICU environment with high level of acuity patients? Can we obtain preferences when the patient might be such as Steve, who is flipped upside down in a rotoprone bed and is completely sedated and unable to give us his wishes on what he likes to listen to? And what is the dose and frequency that we can use in the ICU? We know from pediatric studies they have used music therapy in the past, and they do it in the adult population too, but that's not scalable for the number of admissions that we have and the complexity in the ICU. And we know that in nursing homes, there are programs that are using headphones and MP3 players, but can we bring this to the intensive care unit? So to do that, we designed a study, which is a feasibility and acceptability trial called DDM, Decreasing Delirium Through Music. And we performed the study at Eskenazi in their medical surgical ICU. We included patients who had dementia or chronic neurologic disease or had drug or alcoholic intoxication, and the usual other exclusions are listed here. And our hypothesis was that music intervention in the ICU would be feasible. We would achieve an enrollment and recruitment rate of about 40%, which is fairly standard for ICU trials. This is a difficult to recruit population. We would randomize, design the playlists and initiate the intervention within 24 hours of enrollment. And we would enroll patients within 48 hours of them going on to mechanical ventilation. So early on, so that we don't have a lot of background delirium going in. And that it would be acceptable, rated at least 80% acceptable by patients, and the adherence would be high, at least 80% of sessions would be delivered. And we would also estimate the effect on delirium, anxiety, and pain. So in our published protocol, as I show here, we anticipated 1 year of study enrollment and recruitment with 20 in each arm in a 3-arm study. We'd have personalized music, so patients in a single blind fashion where we wouldn't know what they're receiving would get a MP3 player programmed by one of our unblinded interventionists based on preferences obtained from family. Compared to non-personalized music, which was slow tempo classical music based on evidence that we had found in the literature, and attention control, which was an audiobook. And we performed twice daily level of sedation and delirium assessments, as well as monitored their level of sedation, et cetera, and doses of medications for up to 28 days in the hospital. The intervention period was 7 days. So as you can see from the consort diagram, we screened 1,595 unique admissions, and we enrolled 56 patients. 52 were randomized, 17 in the personalized music, 17 in the non-personalized, and 18 in the attention control. You'll notice that our withdrawal and rate in the attention control was higher, and I'll talk about that in a second. If you look at our baseline characteristics, this was a sick group. They were on a mechanical ventilation of a median 2.5 to 4 days, as well as in the hospital for about 2 weeks. And their Apache scores are consistent with other ICU studies. Randomization worked pretty well. So our recruitment outcomes We conducted the study for 11 months. We recruited 56 patients who signed consent. Only 7.8% of the eligible of the screening pool was eligible, and 45.2% provided consent. In terms of our adherence data, we had 80% of sessions delivered in personalized and non-personalized groups. Patients did not like the attention control, and that was the group with higher dropout rate as well as higher refusal of the intervention. And so we only delivered 30% in the attention control because I think the audiobook is a difficult format. If you look at our acceptability data, this is a random survey of our participants in the study, and they came from all three groups. 80% found it enjoyable. They found the headphones to be comfortable. The session duration of 1 hour each was acceptable to them as well. And 90% of them would enroll in the study again. However, 80% would like to choose their own music, which is not a surprise. If you look at our delirium data, now keep in mind this is not powered to show a difference. This is entirely exploratory to help us design a larger trial. You'll see that the mean delirium coma-free days was higher in the non-personalized group, and the mean RASS scale was lower in the same group. And that basically equates to those patients were less sedated. And we know if a patient is less sedated, they're less likely to have delirium. And if they're less likely to be, if they're less sedated, they're also more likely to engage in physical activity, getting out of bed, perform ventilator weaning trials, and basically together have less risk for delirium. And you can see that 75% in the non-personalized group were able to achieve standing status during their ICU time. So they were actually able to get out of bed and stand, whether or not they were on the ventilator, which is the benchmark that we try to achieve because that's been associated with fewer delirium days. Very exciting data here because of the small sample size, and yet we're already seeing a signal. If you look at the medication exposures, patients in the non-personalized group received less haloperidol, an antipsychotic that's often used to treat hyperactive delirium, and less quetiapine, also used for delirium and as an antipsychotic in the hospital. And these patients received less benzodiazepines, which are independently associated with delirium. So this also fits with our signal that these patients had less sedation. So what did we learn? Well, likely, given our hit rate of only about 7.5% of the total eligibles, our exclusion criteria may need to be relaxed for a larger study. We are actually in the process of applying for a R1 for a music study, so this is very useful data for us to submit. The choice of music matters dramatically to the participants. Their number one reason for refusing to be in the study was that they only want to hear what they want to hear. They don't want to take the chance of listening to something else. However, interestingly, once they were surveyed, acceptability and adherence for both the non-personalized as well as the personalized arms was high. It was at least 80%. It was low for audiobooks, and I think that's an area that we cannot use the same audiobooks if we go further, and we may need to investigate white noise or a different attention control device. The intervention was feasible without daily involvement of a music therapist, which really is a difference from any previous study in the ICU involving music. There's always music therapy involved. And we found that we are able to, within 24 hours, we are able to personalize a playlist for patients who are coming into the intensive care unit, even if we don't know their preferences firsthand, but we receive them from a family member. Our algorithms are good. They are with high acceptability, and we are able to deliver the intervention in a feasible manner. And there is a signal for greater delirium and coma-free days, less sedation, and potentially less delirium severity in this group. So future directions, we are currently testing a personalized iPad application at Eskenazi in the intensive care unit that delivers music to these patients, and we are able to track exactly what they listen to. We're also embarking on mechanistic analyses of why does music work and why does it help, and bringing music to the outpatient setting, working with CBCI as well as the CCRC over at Eskenazi to bring music intervention to patients who are ICU survivors as well as dementia patients. I'd like to thank Babar, Malaz, Sugao, Chenja, one of PhD students in biostatistics, my collaborators Linda Klein and Annie Heiderscheit at Mayo and Augsburg, as well as the rest of the research team, without whom this would not be possible. And I'm happy to take questions. This is a graphic from Spotify and Google, which shows what are the top artists, pop artists in the state. And if you don't recognize some of these people, it actually lists it out by state. So happy to take any questions. Yes.
So question on your outcomes. So you had a lot of data, so I wasn't quite sure what I'm going to summarize, but it seemed like the non-personalized group, I don't know if you interpret those as a trend towards better outcomes in a few categories, like less sedating medicines, and they were standing quicker. So the question I have is, I'm not sure you conclude that personalized is better than non-personalized, except if you ask people, would you like to listen to music you like, they're going to say yes. But the outcomes didn't support that. Am I correct?
You are absolutely correct that the non-personalized arm is the one with the best outcome data. And there is a school of thought, which is why we incorporated the slow tempo music, because it is likely to entrain and relax the mind with reduction in heart rate, blood pressure, et cetera. So there may be an anti-stress reaction, which may then be due to lower stress levels. There's improved relaxation, so you have less sedation exposure, so you're able to mobilize them sooner.
My only comment is if you propose for your RO1 a 3-arm trial, which would require more, you might want to figure out this choice of music matter and have a music arm, maybe tailored versus a non-music arm, just for sample size.
You are absolutely right. So we are actually going to propose a 2-arm. And one of the ideas that we've been toying with is that perhaps they need, during their most acute phase when they are hanging upside down in the room, they might need a non-personalized playlist. And then once they're actually on the floor and able to interact, switch them over to a personalized playlist.
Yeah, sounds good.
Yes. They received it for up to 7 days in the ICU. Right, and I can show you that the number of sessions, I may have it on, I have the data, but it's 3 to 4 days is where we're at for each group, and that's kind of what we're targeting for our follow-up study.
Would you be investigating whether non-personalized music indeed has a different effect, or investigating whether particular types of music have different therapeutic effects on a patient?
That's a great question. So thanks to our research team, particularly to Lev Inger, who's in the room, we have a list of every track that the patient received. So along with our new app that's collecting even more granular data, we hope to go back and analyze and see if there's a signal to the specific tracks that we would then use for a follow-up study. So yes, we are interested in exactly what they're listening to. And from Spotify, we actually get a lot of in-depth track data about beats per minute, tonality, rhythm, pitch, etc. So we could build a model to predict what would be the best based on patient demographics.
I actually wonder if it has a similar effect to, say, varying what kind of puzzle you do in the morning, right? There's been studies that have been done on neuronal connectivity. If you switch up what kind of puzzle you do every morning, it actually improves your mental capacities. And I wonder if listening to new music that they haven't heard before perhaps has a better impact than music that they are more experienced with.
That's a great point. Yeah. Okay. Thank you.